We'll move over to our first live case site straight away.
Good morning, that Sanjay Kalla, Ganesh on the podium, and my sincere thanks to Srinivas Kumar for his commitment, hard work, and excellent meeting at TCT, giving us the opportunity, entire committee of the TCT India. So without wasting time, I will introduce Dr. Kapardhi, and Dr. Kantilal, Bharati, and Madhu, and Dr. Narendra, our colleague, Kiran, Vishwanath, everybody here. So with this presentation, we'll go. Dr. Vishwanath, please.
Dr. Vishwanath, good morning. The first intervention here.
The presentation, please.
Yeah. We have a 55-year-old man who essentially has no traditional risk factors for coronary artery disease. He presented with mild effort intolerance of a few months duration, and at the time of presentation had a normal resting ECG and a normal LV function.
Not able to hear.
His treadmill test was positive for inducible ischemia in a significant fashion, and his workup revealed normal renal function. So he had an angiogram done at a different facility about 15 days ago prior to the intervention, which we'll just show you. So this is the index angiogram. As you can see on the left side, we have a septal collaterals feeding a totally occluded right coronary artery. And there is also a osteoproximal disease of the left circumflex. So with this in mind, with the CTO PCI, we did an MSCT. And the MSCT also showed a CTO segment with some calcification, specks of calcification in the proximal segment. So having this done, we have taken him up for an intervention today.
So, Dr. Tiwari, I'm going to just pause with you for a moment. Maybe we'll kick it to the panel, Dr. Tiwari. So you've got a 55-year-old guy, effort angina, RCA, CTO, looked like a proximal cap at the level of a small side branch, and you've got some retrograde collateralization into a decent-sized PDA, and then some collateralization into an RV marginal branch that's epicardial. What's your sort of first primary approach? Do you feel like you want any more information?
Yeah, you also mentioned about some hemodynamic support for this patient.
No. Dr. Kalla, can I go ahead and tell something?
Yes,
sure,
Dr.
This patient had a very small stump. We see little lower origin of the RCA. Guiding support is a real problem. I took a radial for this short segment. I thought a short segment on the CT. My colleague must have shown with some calcium specs, but it looks more than 20. And there's some calcium on the IVUS. I will show a 270 degrees calcium. And support is a real issue, but I took a radial only with the AR. Usually I use AL, but in this case, the down facing the RCA, I took AR with side holes, AR1. And this is done with micro fine cross with 6 French 2.5 balloon trap is comfortable. So I initially went into subintima, the fielder XT. I thought the soft tissue tracking, but it's not like that. If you carefully see, you can a small hematoma produced. That's why I escalated to a wire of a Gaia 2. As you can see that first wire is in the false stack. So then I came back, readjust the fine cross to the tip of the catheter with a cyan blue. That's the technique what you use not to lose these coronary CTO wires in the beginning. And then I usually, people won't use lateral, but I'm fond of this view where I use the RAO and the LAO and the lateral view. And finally, with a Gaia 3, I could penetrate the distal plaque, and then the story after crossing it, we exchanged the fine cross and dilated with a 2 millimeter UV balloon. Then we have done the IVUS. You can see the IVUS. Are you able to see the IVUS? Are you able to see the IVUS?
Yes, we can see the IVUS coming down.
Yes.
See a relatively diseased
there is distal diameter of around 2.75 and proximal around 3.2. So there is a calcium, but at the site of CTO, there is very hardcore calcium, intimal calcium.
So there's an arc of about 180 or so degrees of calcification. There are discontinuities within the calcium.
I used the Wolverine 2.75 balloon here before doing any stenting. Then after that, I went ahead with synergy of 2.75 into 24. And we post dilated this with the high pressure balloon up to 18 atmospheres, and finally achieved this result. We have done osteal flaring also. This procedure is completed radially with one 6-French sheath. I was done again. You can see the I was.
That's a lovely final result. It's a was live case, not so much a is live case.
So at the same time, he had a left circumflex osteal lesion, very nasty lesion in the circumflex. So just now we are finishing this way. This is we have done again with the same Wolverine 2.75 positioning, not to get into the left main.
Sir,
and
maybe I'll stop you. I'm just going to stop you right there, and let's just
Please.
pause for a moment to be able to discuss the
Please,
case,
please.
because I think we've gone awfully far, awfully quickly, without really talking a little bit for the benefit of the audience on how your
Okay.
decision making went.
Okay, okay.
So we've got a dual vessel case where you've got a CTO of a right. Can you show us the circumflex angiogram, please?
Yeah, please.
Let's see the circumflex angiogram, please.
Back,
Just
back.
come back, please, before the
Back,
intervention.
Back.
The idea of a live case is that the majority of it should be done live. So let's see if we can engender some discussion before we see the final results. So you've got a proximal circumflex lesion. It's a modest to large size circumflex, at least 2 obtuse marginal branches.
Yes.
The lesion is very proximal in the circumflex without a ton of retrograde collateralization from that territory. So this patient's living largely on retrograde collaterals from the LAD into the RCA prior to recanalization, and you've got a tight circumflex. Okay, sorry about that interruption. We're going to come back to you. Dr. Kasturi, you've got, just to summarize this, we've got a 55-year-old with an RCA CTO that we see now is recanalized, but let's go back to the beginning of the case. You have to make a decision between dealing with the CTO first or dealing with the critically diseased proximal circumflex first. What's your first approach, and why might you do that?
It all depends upon the clinical symptoms. What kind of symptoms is it? I don't know, because I joined very just now only. I have not listened to the history also. Good morning, Surya Prakash and Kapardhi.
Good morning.
Sridhar
Kasturi,
Kasturi.
please.
Good morning. LCX, to be frank, it's not that critical.
No. Then
Yes,
see the angiogram.
Just can you show me all the angiofilms?
First angio, let him show.
Yeah, I think the picture
And they
you saw
compared
was after a balloon
Yeah.
was dilated there.
If it is too critical, better to do the LCX first and they're going for right coronary. Otherwise, if it's like more than 70 to 80, like only 70
Let
to
me
80
show the
percent,
angiogram.
not like a 99%.
Left.
Then do the CTO and subsequently you can do the LCX.
So I guess this comes down to strategy, right?
Yeah.
How much myocardium are you going to encumber by
Yeah,
what
yes.
approach? Here, I think the plan was to do the RCA antegrade, to do the to do the circumflex with as a standard angioplasty. So
Yeah.
I guess, is there, Dr. Tiwari, is there an effect of whether or not you would choose the circumflex first if you planned on doing a primary retrograde RCA?
I think seeing the morphology and the complexity of the RCA, it was justifying to do the RCA first. And so they did it. And now with a favorable angle from the left main to SIR.
We are,
I guess in the land of sort of severe LV dysfunction type patients, I think if you have normal LVs, then it's quite safe to do whatever you choose to do. But in general, if you're going to encumber a myocardial territory by doing a retrograde, you're going to encumber both the collateral territory as well as the antegrade territory or the target territory. In those situations, my practice is to try to actually do all of the other lesions first and then decide on that next one, right?
do you only osteal setting up the LCX, Dr. Kapardhi?
Yeah. Only osteal
Osteoproximal lesion in the angio, it's very tight lesion actually.
And
What I meant to say,
yes.
It is opened by two other
strategy wise, are you
centers.
going with only osteal stenting or LM to LCX stenting?
No,
No.
osteal stenting,
We went
osteoproximal
osteal. We
stenting.
don't want to
Planting
do
zone, 90 degrees
And we
angulation.
checked the I was
think
also very comfortable.
We saw
with
that the PCI was imaging guided as well, right? So presumably you had some sort of a landing zone at the ostium of the circumflex where you're able to put that.
Exactly. Yeah.
But recently there is a consistent statement. If you are doing, particularly if the osteoproximal LCX lesion is there,
Yes.
it would be preferable to go with LM to LCX because you will have more control. The restenosis, the rest, like
yeah,
LED
then,
osteal, LCX.
no, there are many methods of doing the osteal thing. If you have a proper views, your understanding is good. Most of the times you can avoid the left main to circle. What I feel, if LED is normal, that too.
Here
Try
that,
to jail the LED
yeah,
and
yeah.
all.
That Kasturi, here the favorable angulation is there between the circ and LED 90 degrees with the landing zones are good.
Okay.
And the distal left main is not diseased as per in the IVAS also. That's why the strategy
14.
So I think
osteal
that-
stenting.
That's
Hey, guys, just
probably
one-
your most important point, right?
Yeah,
Is you've done the imaging ahead of time. You
regarding-
understand whether or not the true ostium of the circumflex is diseased and whether or not there's disease at the distal left
Yeah.
main. And that allows you to design a strategy where either you have a landing zone
Yeah.
or you don't. If you don't, you're crossing over. If you do, then
I
you.
think we have to read many views to find the
Yes.
landing zone. In
So, Dr. Surya, hey, Arun here. Real
please.
quick question. I mean, first of all, very, very nice case, very interesting. There was just this discussion about, CTO first or the other.
Doctor, I don't know how much percentage of CTO PCA in radial in your practice?
I go radial femoral or bifemoral. I'm not a big fan of biradial in general,
Because,
but okay, can I ask you one question about this case? Like,
Yes.
have you guys imaged left main into LAD per se? And
we have done that.
Sanchag or Dr. Tiwari, would that be
We have
something
done
that you
that.
guys
You can show
consider?
that.
And
We have
how
done.
would that change your practice? Maybe
We can
Dr.
show
Tiwari
that.
can-
We have done it.
You have? Like, do you want to tell us about what you have found and then why you chose that particular strategy?
You can see the I was from the LED to left main. Show the LED
LED to-
left main to this.
Here the why the strategy was selected. Distal left main is disease free. At the same time, osteal LED is also disease free.
And angle is good.
Angle is 90 degrees, favorable angulation. That's why
I think-
we select the strategy.
I think the osteo of the circumflex has a severe disease. And what's your opinion about?
So I think it's worthwhile defining what the nature of the left main into LAD is, because if you have important LAD osteal disease, then this becomes a case where you would at least get a surgical opinion, right? Where you have the ostium of the LAD involved, or you have the distal left main involved, and you have a proximal circumflex with a CTO of the right. Having said that, in this case, I agree, there's very little disease at the ostium of the LAD. The distal left main is disease-free. So it's reasonable to proceed with PCI. And if, again, we didn't see the ostium of the circumflex. If there was a landing zone at the ostium of the circumflex, I think you're fine. The danger is you don't want to leave struts in the carina. It's just technically not an
We
optimal
crushed
move.
it.
So-
We have done a crush. We
Yeah,
show that.
So what would be nice to
kissing
see,
balloon.
what would
We
be
had a
nice to
3
see
into
is the
3
IVUS
kissing
from the
balloon
circumflex to the left main. So why don't we put the IVUS catheter down into the circ, and let's actually see the stent result from the circ to the left main to decide
We
whether or
will
not
check
it's.
it again. We have
top.
done once. Show that.
Can you show the stent and circumflex? Question.
So, but that's a pullback from the LAD into the left
LED
main.
pullback.
We
You
have done
cannot
from
judge the
circ,
ostium of the
after-
side branch from the
We
from the
have done
main
from the
branch
circ
pullback.
and dilated the circ proximal at the
Can you show
328
circumflex?
atmospheres.
I think, sir, I think it looks good angiographically, and we all acknowledge that. But the point we're making is you cannot assess the side branch, putting an IVUS down the main branch. You cannot. And so if you
We
really
put
want to
the
assess
IVUS
that stent
again.
result, the IVUS needs to go down the
You can
circ.
see the circumflex to left main also. I was done.
So let's see the circ back to the left main so we can see the result of this. That's
This is,
beautiful. The distal
after-
landing zone was beautiful.
Yeah.
And it's all it appears to be reasonably well expanded. It would be worth measuring the area because we're right there, for example, because we're shooting for 5.5. So here you see that your stent actually comes back to the distal left main, right? It has crossed over, and it underlines the importance of the fact that carinas and bifurcations are not great assessed and not well assessed on just angiography. So you actually do have a stent across the carina and ending in the distal left main.
And
And the
that's
question
why
I
we
guess
have done
that
a kissing. We have
it
done a
needs to
kissing
be
there.
answered is, are you going to make
Let's
that
show
distal
that.
end bigger?
We have
Are you
done
going
a
to make the
kissing
carina
there.
bigger? Are you going to rewire
see
into the
that.
LED and are
We
you
have
going
done
to
that.
struts? Which I see you've done.
Actually, those studs becomes crushed by and a kissing balloon was done. You can see that angiofilm and final IVUS, you can see the crushed portion with a
3 into
cavity.
3 kissing balloon.
Whatever the studs which are projected.
You can do IVUS into the circle.
My Dr. Surya Prakash.
Hmm.
LED not stent, only L6 stent, no?
L6 only.
See, here if you are doing the kissing balloon, that's the reason if slight extension of the ostial struts into the left main complex. When you do the
One or two stents into the left main, I don't think cause any problem, but we crushed that also.
it extended slightly into the confluence. Definitely the slides are projecting into the confluence based upon the IBS. Otherwise, stent is very well expanded. Landing zone is very good and healthy landing zone, but is projected into the chest encroached onto the LED ostium. With kissing, definitely it clears. But the problem is the NC also causes injury. There is some block in the left LED osteoproximal lesion. Definitely that adds some injury. If you are doing that, better to do the DEB into the LED and go with the NC into the L6 so that the intimal injury can be avoided. That's my opinion.
My IVAS cat also easily entering.
Hey, I think I got,
No problem.
I see Ramesh in the audience and I think he has something to say. So just love to hear what, you know.
No, I mean, thank you, Dr. Surya Prakash Garu. So
Thank
this
you.
is the osteocircumflex, whether we can do DEB is one thing. Then the other one is whether we can do the stopper technique of putting a non-compliant balloon, not very small, but the one-to-one sizing in the LED and bringing
That's
the
what we have done in this.
Yeah, that's what you have done.
That's
Yes,
what I have
exactly.
done.
Was
The
it?
struts were crushed followed by kissing.
We kept a balloon in the LED when we are doing it.
Yeah, so still looks like the stent has come back into the left main. You know, so
You've also got some struts malopposed off of the side of the left main, right? So I think looking back at that last IVUS, you've got a degree of struts that are coming off of the greater curvature of the left main, and you've got some struts that are coming back towards the distal left main. And so this becomes one of those, do you fully expand the stent, circ back to main, rewire, and just open the struts over the LAD? Or do you try to get a balloon behind the stent, crush it, and then turn it into a formal bifurcation? Right? I think that's where we are. Because if you slowly pull this back right here, okay, there, right there. Just come back, go forward right there, right? So just as your LED wire comes in, right there.
Yeah.
Okay. Now your left main is formed, but your struts are not touching the side.
Yes.
Right.
exactly.
So
Exactly.
you can take a non-compliant balloon, short, size it to the distal left main,
Okay.
open it, rewire the LED, because effectively that becomes your distal left main pot, rewire the LED through the struts, and then you do a kissing balloon inflation, which is effectively opening the struts over the LED.
There is a series from Obida group. What they suggested, isolated osteal LED or L6 lesions.
With three balloons.
Many times it's very difficult to
LED, yeah.
precisely place the osteum.
Absolutely.
Recently,
LED.
ABC also, they gave a guidelines. If the osteal lesions are there, ideal to extend to the left main, which is more controlled, even if there is a dissection
Yeah.
or plaque extension to the LED osteum or distal left main, it's a more controlled. You can put balloon and do the kissing and everything. That's the ideal strategy. That's the reason the placement of the precise, like a exact osteolocation, one, it can vary respiration wise, particularly radial approach if you do it, and it can change the so-called, you may say osteal, but it may 1, 2, 3 mm.
Left main lane.
Absolutely. So Dr. Surya Prakash will let you work a little bit. And we're going to move over to our next site here.
I think we're-
Okay. Carry on.
Yeah. We'll move over to our next site.
I think
We'll just
Ajay
keep coming
has
back
something
to
to just add on. So as we move, maybe Ajay
Yeah,
can just
sure.
comment
Dr.
about it.
Kitane, as a quick comment here, just before we move to our next site.
Say it's actually really nice to see this case in contradistinction to the case yesterday that had an OCT, and in this case you can actually see the struts come back into the left
Mhm.
main, whereas the other one yesterday they just stopped at the carina. So yesterday we had sort of said you don't need to dilate the ostium circ anymore because you're only just coming briefly, but when you
Yeah.
cross over, then you actually should make sure that it's well approached because it's
persistent,
basically across.
Yeah, I guess the big point of crossover from circ to left main, which effectively this becomes, right, is that if you've got more struts in the left main, you've got a larger area where you can pot, and you're so much more comfortable taking a non-compliant balloon down that's 1-to-1 size to the main. In this situation, you have a little bit less room, so it becomes technically more difficult to do this, but nonetheless, it's important to make sure the struts are opposed. To your point, from Dr. Surya Prakash.
Madhu. So we have done, you can see the steps what we have done. We removed the wires and circ and crushed the stent, whatever little 1 or 2 struts protrusion in the left main. This is the end result, looks very good. And I usually do this technique. You see the 3 mm balloon going so smoothly and there is no obstruction absolutely. So then result shot, you show that Arivokadali. So it's an excellent result. I think I don't want to put anything metal here.
Great. Yeah, the angiographic result looks good. Do you have final IVUS runs on both sides?
We are doing that.
Excellent. I think that's really what I think we've all admitted to ourselves now, that the benefit of intravascular imaging is just what we've demonstrated here, where you think you've got the ostium of the circ, but in fact the stent comes back, and so you optimize it to get the very best result you can. So this is a lovely, very well expanded stent throughout this segment. There was that little area that it looks like you've now further dilated.
Yes, we
Yes,
dilated with the
dilated.
3O balloon. And
24
after that, the IVUS was also done, which is been on display. And I think the RCA, the main CTO, which was osteal disease and the proximal CTO segment, we did not have much panel discussion onto it, which was the main reason of this case to be
Okay, it's a chip PCI, so we have done the same thing.
It was all done by the time you got to us.
Thank you. Anyway, I think people appreciated the.
Thanks very much for a nice case. There's lots of learning points that we can then
We'll,
discuss
we'll
further
meet
from
in
that.
CTO next year, Sanjay Kalra, and okay.
absolutely.
Thank you so much, Dr. Surabakash.
Thank you.
and
Thank
team.
you. Thanks, Dr. Srinath Kumar, for giving the opportunity.
Great job, Dr. Surya and team.
Thank you.
Thank you.